Okay, good morning, everyone. Thank you so much for joining, for your patience while we get everything set up. It's really wonderful to see all of you. Today, we're going to be talking about elders and disabled adults discharged to homeless shelters from long-term care facilities. And we are so pleased to have Molly, who I'll be introducing in a minute, who's really an expert in this, this whole field. Before we get started, though, I wanted to just let you know a little bit about CSH. We always like to explain what we do. So I am the Associate Director of the CSH Los Angeles office. My name is Gretchen Brookson. Most of you know me, I think, from other trainings. CSH is a national organization, and we do a lending and financial support for supportive housing development. But we also do training and education such as this one, policy reform, and we do a lot of consulting and technical assistance to just address issues related to homelessness. So this series that we're offering, this training series that we're offering is really designed to bring topics to our learners that involve addressing issues around homelessness for older adults, particularly. So that is our goal today. One of the things I want to mention, and we always do this, is that we know that structural racism creates inequity in health and housing for older adults, particularly people of color. So this slide is just a reminder that in all our work, we are cognizant of the need to address these inequities, and we try to weave, I guess, a social justice approach into our, and a racial equity approach into our trainings. Today, we're going to be talking about the Long-Term Care Ombudsman Program. We will be looking at skilled nursing and assisted living, which is residential care facilities for the elderly, and adult residential facilities is the official licensing name. We're going to be looking at transfers and evictions from those facilities, and then really covering strategies to assist residents. So it's going to be a full session. And we are not going to offer a break today, but if you need to get up and stretch, obviously, just do so. So with that, I'm going to turn it over to Molly Davies. Molly is Executive Vice President with Wise and Healthy Aging, and she's in charge of their Long-Term Care Ombudsman Program. So we are going to, I'm going to let Molly introduce herself. There she is on the slide, and tell you just a little bit about what she does at Wise and Healthy Aging before we move on. Molly, it's all yours.
Thank you, Gretchen. Thank you for that. So I'm Molly. I'm with Wise and Healthy Aging, and Wise and Healthy Aging is a nonprofit that provides an array of social services for older adults and their caregivers. One of our programs is the Long-Term Care Ombudsman Program, and we provide that program throughout the city and county of Los Angeles. We're the only service provider that provides that program. Next slide, please. And from that perspective, we're going to talk about elders and disabled adults who are discharged to homeless shelters from long-term care facilities. Next slide. So let's talk about why do you care about this? Why are we here this morning? So the relevance to your work. So today's session is really to provide tools to help advocate for our shared clients, to identify if clients have been inappropriately sent to shelter by a long-term care facility, and then what can we do about it once we've identified that. We want to help make better transitions for our clients from long-term care facilities, and then also intervene if we have folks who we've identified at shelter who do have a higher care need, but rather than calling 911 and hospitalizing them, providing you with another another option. And then we also want to give resources for folks who may have had a bad experience when they were in a long-term care facility. So we're going to learn about the basic transfer discharge rights for residents in long-term care, and then provide resources. When somebody comes who has care and supervision or healthcare needs that can't be provided at shelter. We're going to have a little bit of a conversation about going against medical advice. We hear that a lot, so we're going to talk about what that means. And then we want to talk about what are you seeing, and take this opportunity to learn from what you're seeing in your work. Next, thank you. So we'll start with the basics. What is a long-term care ombudsman? So you have a sense of who we are and what we do, and when you might tap into us as a resource. We're advocates for residents in long-term care facilities like skilled nursing and assisted living and boarding care facilities. It's a federally and state mandated program authorized by the Older Americans Act and the Older Californians Act. And in California, where our program's administered at the state level by the California Department of Aging. And then they contract the service out to the local area agencies on aging. And then either the county offers the program as one of their county programs, or they contract it out further to a nonprofit or legal services organization. And that's the case here in Los Angeles. So in LA, the city and the county both contract the long-term care ombudsman program to Wise and Healthy Aging, our nonprofit. And we have 6 regional offices throughout Los Angeles. We're also looking to open our 7th office. So our offices are in Santa Monica, Van Nuys, Pasadena, Long Beach, Montebello, and Torrance. And we are looking to open an office in the Lancaster, Palmdale area. We have 30 staff, about 25 volunteers and interns, and we're responsible for regular coverage of 1,800 licensed facilities in Los Angeles that have the capacity to serve at one moment in time about 76,000 clients. So what do we do? So the ombudsman's role is to identify and investigate complaints that are made by or on behalf of residents in these facilities. So either we get complaints that somebody calls us over the phone, or when our ombudsmen do conduct regular unannounced visits to these locations, because that's also part of our responsibility. That's also where we hear and take complaints from residents, or we observe issues that we bring forward as complaints that we've seen as ombudsmen. We're also there to help educate residents and their loved ones about their rights, about facility regulations, about what they are entitled to, about how to pay for long-term care. So we do a lot of consultation with our clients, and we call our clients residents. I should have said that. In skilled nursing facilities, we witness advanced healthcare directives. If a resident of a nursing home wants to create an advanced directive, it's not a legal or valid document until it's been witnessed by an ombudsman. And sometimes we are able to witness them, and sometimes they aren't, depending on if the client wants the document or not, or the capacity of that individual, if they have the ability to create such a document at that time. And then we're also charged with conducting preliminary investigations of suspected abuse and neglect that occur in these settings. So we're one of 5 states that the ombudsman is in that role. So sometimes people will say, oh, so then you make the referral to APS. Nope. We actually do similar work to APS when it comes to abuse and neglect investigations in facility settings. There are some times where we have shared jurisdiction over cases with APS, and we work together on those. But primarily we're responsible for those kinds of complaints. And then we monitor the quality of care for a healthcare facility if they're going through bankruptcy, if the bankruptcy court appoints us as the monitor, and then we report our findings to the court. We've done that on a number of occasions. So what kind of things do we actually address, and what is our process? So we can look into any type of complaint related to quality of care, quality of life, very, very broad. So not only elder abuse and neglect complaints, not only transfer discharge complaints, but, I'm not getting my physical therapy, or they're telling me I have to discharge home tomorrow and I don't have anyone to care for me. I'm not getting access to my medical records. I think I have no idea what medications I'm on. So a real variety of issues. Also social issues, right? Things that come up between roommates, things that come up between families. So lots of issues that we get involved in. But we do a lot of work around transfer discharge rights and eviction issues. We answer questions about services that should be provided, and any issues related to dignity and respect. We deal with a lot of issues around that. Our program is resident-centered, resident-driven, and consent-based. And we really err on the side of self-determination over protection. So we have a harm reduction focus. We do have a process for how we can help people who don't have the capacity to consent and don't have a legal decision maker. So there is a way for us to help get involved with those cases. So some of our collaborations might be some of the folks that you work with too. So we work with the Department of Health Services, Housing for Health, Managed Medi-Cal Health Plans, the Department of Mental Health, the ERC program, regulatory agencies, the Department of Public Health that is working on the COVID response, so the ACDC side of the house, fire departments, law enforcement, city attorneys, a lot of different collaborations. That's how you find us, and that will be in some other materials that we'll provide you as well. It's our central intake process. Phone number, after hours crisis line for emergencies that happen after our business hours, and then an intake email also for folks who like to put things in writing. So some questions for your consideration. What do you do when a client comes in from a skilled nursing facility or assisted living that can't be cared for in shelter? You hear about that happened for one of your clients. How often does it happen? And do you feel confident in handling these types of situations? So those are some things that we're wanting you to think about.
Molly, I'm going to jump on and say that if folks could be thinking about that and maybe put their answers in the chat, we will have Molly take a look at your how you respond to these questions maybe toward the end of the session.
Yeah. So let's talk a little bit about long-term care facilities. There's sometimes confusion about what's what. So I'll be really, really brief on this, but skilled nursing facilities are sometimes called nursing homes or convalescent homes or rehabilitation centers or wellness centers, but they're all licensed. They're all licensed like skilled nursing facilities. Residential care facilities for the elderly, that's the licensing term. And those are also referred to as assisted living or board and care homes or retirement homes. Sometimes we refer to assisted living as the larger facilities, right? So they have, 100 or hundreds of people living in them. And then the board and care homes we often think of as, the little 6-bed homes where they're a little bit more home-like, a little smaller environment. So what's the difference? So skilled nursing facilities provide 24-hour skilled care, wound treatment. They provide complex medical treatment. So for lots of different conditions, physical therapy. They are for people that need care, supervision, and medical treatment, either for a short period of time or for a longer period of time, right? So we have some people who come to therapy after they have a hip surgery and they're there for, to do physical therapy and then go home. Or you might have somebody who is now bedbound and is on a gastric feeding tube, and they're going to be there they don't have the resources to do that at home. It's a everything can be done at home if you have enough resources to do it. Everything can be done at home, right? That can be done in either of these environments, but it's very, very expensive. And Medi-Cal doesn't pay for the robust amount of services in home that they do pay for in skilled nursing. So we do end up having more people who have those complex medical needs and care and supervision needs living in skilled nursing for the remainder of their days because they don't have the ability to do that at home. And so there's more regulation of skilled nursing facilities than there is for residential care. And primarily that's due to the fact that there is Medicare and Medi-Cal reimbursement, and it's a national system, right? So there's federal regulations that facilities are required to follow, and then there's also state regulations that they're required to follow, and they're regulated by the Department of Public Health. And then residential care facilities for the elderly, also called assisted living or board and cares, they provide 24-hour care and supervision. So they don't generally have nurses on duty, although some of them will. They're not required to. They are less regulated. They're regulated by state regulations only. And really these facilities were created to have more of a home-like environment, but the thought was people were healthier. But the reality is we have a real array of individuals who live in these facilities, and many of them are quite, you would think, looks like somebody who might live in a nursing home living in this environment. These facilities are private pay or paid for at the SSI rate, or now we have other programs, right? Like the ERC program that does some reimbursement for them that's unique to Los Angeles. There are some prohibited health conditions. So there's some conditions that if that person has it, they are not supposed to be in a residential care facility, like a stage 3 or 4 bed sore, for example. Somebody who's total care. You can get some waivers and things if people are on hospice, but for the most part, people who have gastric tubes and that sort of things. The ERC is the Enriched Residential Care Program. Yeah. Sorry about that. And then the RCFEs are regulated by community care licensing. So who lives in these facilities? So a resident of a skilled nursing facility or an RCFE or an adult residential facility. The adult residential facilities are for younger folks. We'll talk a bit about that. So residents in skilled nursing and residential care facilities are generally older adults who need care, supervision, and medical treatment. Some are younger who have disabilities, right? So it's based on care need and compatibility. Residents in adult residential facilities are generally younger, 18 to 64, and some of those facilities are cater to folks with developmental disabilities, and then some cater more towards individuals that have more persistent mental health diagnoses. So let's talk a little bit about what these facilities are obligated to do for a resident as it relates to transfer discharge issues, because that's just kind of wanted to set the stage, and now we're going to dive into what we're here to talk about. So skilled nursing facilities, residential care facilities, adult residential facilities are required to ensure that the discharge is necessary. It's for one of the legal reasons for discharge, that the discharge is safe and orderly, that the level of care that the person needs is determined by the doctor with input from the facility, of course, but those determinations should be made by the doctor. And that residents are involved in the planning of the discharge. It shouldn't just be like, we're moving you here, which is what happens frequently. Residents need to agree with the location that they'll be transferred to, and the facility needs to provide due process, including a 30-day notice. In some cases, longer notice, depending on the situation, but for our purposes, it's mostly a 30-day notice. So there are certain legal reasons for transfers and discharges out of skilled nursing facilities, and the facility has to have, follow one of these, must have one of these reasons and follow the proper procedure for transfer discharge, which includes a 30-day written notice, which cites one of the 6 legal reasons for transfer discharge. So those reasons are the person needs can't be met at the facility, and the resident's welfare is at risk if they stay there. So what does that mean? A lot of times facilities will say, they have behaviors, right? Or, we just can't meet their needs. This is a pretty small window. It's really, really specific to the person needing a higher level of care, right? So the nursing home can't care for somebody who is ventilator dependent if they're not a specially designated, subacute type of nursing home, right? So that's a higher level of care that, yeah, okay, this person could, maybe need a higher level of care. If the person is in an unsecured environment and they have wandering behaviors, that is an unsafe place for them. They need a higher level of care potentially, right? So it's really pretty tight, right? Because when we have facilities who say, well, we'll say, well, where are you discharging them? Well, I'm going to discharge them to the, the ABC SNF down the street. Well, what are they going to do that's any different than what you are going to do? Nothing, right? So the second reason is that the resident's health is improved and they don't need nursing home care, or they require a lower level of care like assisted living or going back home. The third is that the safety of other individuals is endangered by the resident if the resident were to stay there. And this is a very, this one is used very scantly. So it's not used very often, because you can have somebody who has become physically aggressive with another resident or a facility staff member. They transfer them to acute psychiatric. They, adjust their medications. They observe them, and the doctor there says they're ready to come back to the same level of care. They should be able to return, right? So that's not what we're talking about. We've had individuals who. So it's pretty rare when number 3 is put in place. It can happen. It definitely can happen, but it happens infrequently. Number 4 is that the health of other individuals is endangered by the retention of that resident. So, for example, if you have a resident with active TB, right? So, I mean, again, there are slim reasons, but it can happen. Number 5 is if a resident, after appropriate notice, has failed to pay, but like their share of cost, if they have a share of cost. If they fail to pay, but they still need nursing home care, the nursing home is required to find them another facility that will accept them. So they can't just say, we're going to send you to the hospital and not let you back in. They can't say, we're going to send you to a homeless shelter. We're going to send you to assisted living. They have to find them the appropriate level of care. It can't be payment based, right? Like you're not paying, so you mysteriously don't need care anymore. And then the final reason is if the facility shuts down, ceases to operate. So when a nursing home transfers a resident to shelter, here are some things that one can do. Contact the facility and negotiate the resident back in, citing, finding out what if one of the legal reasons wasn't followed, the noticing period wasn't given, let the facility know that the residents' needs aren't manageable at the shelter. They can't take their own medication. They need help with toileting. They need help with bathing, right? Let the facility know that the residents have a right to a safe and orderly transfer discharge, which includes being transferred to the appropriate level of care. And then also let facility staff know that you understand that the resident has the right to appeal with the Department of Healthcare Services. So the Department of Healthcare Services, they have an Office of Administrative Appeals. And oftentimes when you say that, they will let the person back in. It's often the only thing that you need to say to get the person back in, because they're like, oh, great, somebody knows the rules over there. Next slide. So this is where you would make an appeal. So if they won't let that negotiation doesn't work, then the appeals office number is there. One would be requesting a readmission at hearing. And we have some residents who will do this on their own because they're capable of doing this on their own. We have some residents who we will help them do this. And we have some residents who a hospital will help them do this, but a shelter could help them. Any interested party can help somebody do this. So the Department of Healthcare Services Administrative Appeals is at the state level, and then they will schedule a hearing. Usually the hearing will take place at the facility or where the resident is currently staying. And we generally win these appeals. It's an administrative hearing officer from DHCS. The facility staff participates. The resident can participate. Anybody who has knowledge of what's going on, like shelter staff can participate if they had contact and conversation with the facility about what was going on or what the resident or the client had told them, they can participate. The ombudsman can participate. And certainly family members can too. So the Department of Healthcare Services, they're the ones that will make the decision about an appeal. But the Department of Public Health, Licensing and Certification, they're the people that you can make a complaint against if the facility is violating a transfer discharge right, or neglect, depending on the severity, of the situation, right? And Department of Public Health enforces the appeal decision made by the Department of Healthcare Services. So there's also daily penalties if the person isn't let back into the facility and they win the appeal. So there's a lot of tools at our disposal if this type of thing happens. And like I said, generally, most facilities will just say fine and let the person back in. But there are times where we do have to go through all this process. So just want you to have an understanding of what it is. Next slide. You can also call our office, and that might be the thing that you do first, right? You could do all that other stuff, but you can call our office and see if we can help explore the discharge if the client wants us to, negotiate getting the resident back into the nursing home. We can request the appeal if our resident gives us permission, or if they can't consent, their representative consents, or if they don't have a representative, actually, I'm designated by the state to give consent to my staff to intervene for people who don't have capacity and don't have a legal decision maker. So what can we do? Some of the things that we can do, some of the barriers that are often in place are, well, yes, we know it was a bad, okay, we see that, this person maybe needed a different level of care, but we're so sorry, we don't have a male bed, we don't have a female bed, we don't have a, whatever bed you're looking for, they don't have. So one of the things our office is entitled to is the facility census. So we can get the facility census and say, oh, but we do see you have an available bed for the person that is needing a space. And we know that they didn't get their eviction notice. And we know that, they have a stage 3 bed sore that can't be treated at shelter or an unlicensed or whatever. We can also, with permission, get medical records from the nursing home so we can support, was the person healthy enough to go to shelter? Was the process followed? Is there a doctor's order for that, kind of signing off on that level of care? Was the resident involved in this process? We can also attend the appeal hearing at the invitation of our client, and it's an assistant helping them assert their rights during the hearing. We can make referrals to the Department of Public Health with permission from our client. And we can also consult, right? So it might be, you're not sure if this is something, is this really a bad transfer, or was this okay, right? Because every case is a little bit different. So we can certainly consult with shelter staff, with residents and family members, and sort of anyone who's working with folks who are in this situation. So we're going to move on to talk about transfers in residential care facilities for the elder. I'm just wondering, Gretchen, are we taking questions at the end?
Yes, let's do that. And Gina and I are helping to answer questions as they come in the chat.
Great. So if you have questions along the way and you want to put them in the chat before you lose your thought, please feel free to do that. So for residential care facilities for the elderly, assisted living or board and care facilities, the facility, there's not as much process, right? There's not as much process around this type of discharge as there is with, there's not as many mechanisms, I should say, as there is for residents in skilled nursing. So facilities have to give a 30-day written notice. It has to contain one of the legal reasons, which we'll go over, for eviction. If the resident disagrees with the eviction, then the resident is not required to vacate the property until a ruling is made. As far as, it's RCFEs are interesting because there's some aspects that are tenant landlord and some that are not. So like they're not, they never are part of rent control, for example, but the only way to really remove someone from a residential care facility or an adult residential facility is to go through the unlawful detainer process. So one of the reasons for eviction is if there's non-payment for basic services within 10 days of the due date, failure of a resident to comply with state or local law after receiving a written notice of the alleged violation. And a lot of times these steps are missed. So it could be that, yes, there were violations, but if any of these steps are missed, then it helps support, rescinding an eviction, whether it's in writing or it was given verbally by the facility administration. The third is to failure of a resident to comply with general policies of the facility. And these policies have to be in writing. They have to be part of the admissions agreement. The purpose of living harmoniously with others. So we do get some residents who are given eviction notices because they are not living harmoniously with others. But there should be other steps in between rather than just jumping to eviction, right? There should be, sometimes we'll negotiate doing behavior contracts or, different agreements, some coaching with them and that sort of thing. But the knee-jerk reaction shouldn't be eviction or ignoring the problem and then eviction, right? Which sometimes we see. The fourth reason is if after admission, it's determined that the resident really has a need that was not previously disclosed or identified, and a reappraisal has been conducted, that person needs a higher level of care that the facility really can't manage for, or they have one of those prohibited health conditions. And then if there's a change of use in the facility or closure of the facility. And we've been seeing that happen quite a bit, right? Next slide. So if a resident transfers from a residential care facility to a shelter, and the person really has needs that are not manageable in the shelter setting, or just want to explore it a little bit because rehousing someone is much more difficult than getting them back into a place that they already have paid rent for, right? Or they already have a right to be in, right? So these are some things that we would advise. So if the rent has been paid for the month, then the resident has the right to return to the facility, right? It's like your apartment, right? If you paid rent and you went to the hospital, no one would be like, well, I'm sorry, we're just not gonna let you back in. No, you turn the key and you walk back in. It's your apartment, you paid for it. It's the same in this setting. Until there's a proper eviction, if they've paid rent, that's their place. We want to assume that they have not intentionally given up their room, because that does sometimes happen. If the resident has not been given notice and or they need a higher level of care than a shelter, then I would contact the facility to try and negotiate the person back in. If the facility refuses to readmit that person, then complaints can be made to Community Care Licensing, which is the regulatory enforcement unit, and they have a centralized intake. It's a statewide centralized intake. And then you can also contact the Ombudsman program, so assist with negotiating the resident back to the facility, and with licensing. So sometimes we'll be like, oh, there's a bad transfer. We'll just, call somebody we know at licensing and say, this is the situation, we run it by them. And, sometimes, they'll be like, oh yeah, that's terrible. We'll give them a call, and it just ends it right there. Right. Or it at least gets them back in the facility. And then we can start, sometimes maybe there is a real reason for eviction, but they still have to go through the process. Right. And it still then buys us some time to find a safer transition for that person. Great. So I created a guide for elders and disabled adults who are discharged from homeless shelters from long-term care facilities. And it's a guide for homeless and emergency shelter operators and advocates, but really it's a guide for anybody who's trying to help understand the rights of transfer discharge rights of folks who live in this environment and might want to help them get back in. So it has all the regulations, it has tips on how to negotiate people back in, it has all the phone numbers that are in this PowerPoint and more, and certain things to ask for, certain phrases to use to get the best outcome for your clients. Next, and Gretchen will make that available to all of you. So let's talk a little bit briefly about self-determination. So elders and dependent adults, they have a right to make their own personal decisions, even if they don't seem like they're in their best interest, which I know you are all very acutely familiar with. And it's only if the person meets 5150 criteria, that those rights can be removed from them, right? So if they're suicidal, they're homicidal, they're gravely disabled. So self-neglect is not against the law. I think this is something, there's sometimes a reaction that folks have, like, can't somebody do something for this, 90-year-old person who doesn't want to, who's making some really, really risky decisions. And although self-neglect is something that is reportable, it's certainly not illegal. And we can't force people to do what we want them to do. And then we're going to talk really briefly about cognitive impairment. So this is something that comes up frequently. So folks with cognitive impairment, they still retain their rights and their right to self-determination, even if they're making really, really unsafe choices. And it's only through a court process that these rights can be removed from them. So this comes up frequently. We have somebody who is very cognitively impaired and they want to leave the facility. And so we might have a facility who says, well, they ended up in shelter because they just left, right? Which could be, that could be. But the facility should be doing some things to trying to do some things to redirect the resident back in, try and convince them to stay so that they have time to make a safe transfer, contacting our office to help, for us to help intervene and do the same. make referrals to public guardian for conservatorship if they really are. We have a lot of clients who consistently are making, I wouldn't even say poor choices. They don't remember what the choice was after they made it, right? And so it can be a very tricky circumstance. And then calling law enforcement and licensing if the client leaves against medical advice, like they discharge against medical advice, and they're unsafe. They're very unsafe out in the community on their own. They can't protect themselves. They can't find food. They can't do all those sorts of things. So it's not okay for them to just say, well, they were cognitively impaired. They said they want to leave. Yes, our office does advocate for people who are cognitively impaired to just leave if that is their choice, but we will try and do some of these stopgap things to try and redirect them and that sort of thing. But it's a very, very tricky issue. So let's talk a little bit more again about AMA. A lot of times facilities will say that, well, the resident left AMA. They left the facility against medical advice and else, so we don't have to let them back in. So one of the things that we find happens frequently is that the residents may have gone on an outing against medical advice, but they never intended to discharge against medical advice. But a facility will say, you left AMA, which technically they did. And they will apply, you discharged AMA to actually, you went on an outing against medical advice. So we like to make sure that when we are having that discussion with them, we are teasing out, are their belongings still there? Because sometimes they'll say, well, they discharged AMA. And we'll get calls in the middle of the night, a resident on their wheelchair on the curb, they won't let them back in. And they'll say, well, they left AMA. And I said, well, where's their stuff? Well, it's in the facility. Well, then I don't think that's a discharge. Most people don't discharge without their stuff, right? It happens, but so trying to tease out, is it somebody going on an outing against medical advice, which is not a reason for discharge? We do not have to do what our doctors say, right? None of us. It's their advice, and we can choose to accept it or not. And that doesn't change because you move into a long-term care facility. Residents do not need an order from a doctor to go on an outing. It's a good idea to have the medical team have input, but they don't have to have that. And then residents do have a right to discharge out of facility against medical advice. They do have that right. We like to just make sure they're not being sort of coaxed into it, paid to leave, which sometimes happens. I've had people who were given money to go to shelter. And then most facilities, again, they'll lump those two in AMA, different types of AMA together, and it gets a little confusing. So what kind of things should we ask if we're trying to figure out if the discharge was a bad discharge? What facility were you staying at last, right? Trying to figure out where they were before. If there's a bracelet with facility information on it, that's a good place to start, because sometimes those remain on the person for longer than just their stay at that facility. How long were you there? What was the last day you were there? That's important, because if they were out on the street for several days, it's going to be harder to negotiate them straight back into the facility. It's not impossible, but it's going to be a little harder, because the facility will say, we don't know what they did during that time, and then we're going to be responsible clinically for treating them. They need to go to the hospital first to get assessed, and then we'll let them back in. So they sometimes will have a case for that, but we could then already negotiate that the person is going to go back to that facility. So then there's not as much disruption for the client. But sometimes we are able to even negotiate when they've been out for several days to get them to return to the facility. Asking them what they were being treated for, were there any improvements while they were there, just to get a sense of, is there still more work to be done at the nursing home? Or there's still more care and treatment that needs to be done at that setting before moving to a lower level of care? do you still have those treatment needs? Do you have the same treatment needs if you're having the wound care, if you're having, were you in the middle of physical therapy? Why did the facility say you had to leave? That's really important, right? Sometimes they'll say, well, you didn't pay, so that's why you have to leave. Well, that's not why they had to leave. So that's not a good reason. Do you know if the doctor said that you needed to go to assisted living, another nursing home? What you're trying to get at, what care level the person might have needed to explore whether or not this was a bad transfer. And did you get a 30-day notice? Were you given choices of where you were going to be transferred to? Did you want to leave and agree to come here? So all those things help get at if it was a appropriate or inappropriate transfer, and help fill in information if you're going to be negotiating with the facility directly, or if you're going to be calling the ombudsman. Those are things that will be important to provide over, and kind of figure out if it's a good or a bad transfer. So when is it okay to transfer to shelter? Because there are some moments when it is okay. So if the resident agrees to the transfer, sometimes we have residents who are like, get me out of here. I want to go back to, where I was before. I want to go back to the neighborhood I'm used to. I don't like all these rules, so some folks do want to transfer back to shelter. If the resident is giving a 30-day notice, this has been loosened a little during COVID, but the notice had to be given to the ombudsman if they were in a nursing home. It has to be one of the legal reasons. And the level of care needs to be such that they don't need care and treatment, right? And they have to agree to go to shelter. So it can't just be like, well, they don't need care and treatment, they don't have anywhere to go, so we're going to just send them there. They have to agree to it. And again, the resident's doctor determines the level of care and if that level of care can be managed at shelter. And then there was one other thing, I don't remember what it, and then the resident leaves the facility against medical advice and then self-selects to come to the shelter. So that could happen, right? So that's why you're looking at, like, what are the days, when was the last time you were there? Because we do have some folks who do really check themselves out essentially against medical advice, do whatever they do in the community and then go and seek shelter. And in that case, that would not be an inappropriate transfer from a skilled nursing or residential care facility. And then I put these different questions together on one document for folks in the event that that's a more helpful way to have them. So that's an additional PDF that can be provided to you. All the same things that I just went over, so we don't need to go over them again, but it also then has the ombudsman phone number during business hours and after hours, in the event that that it appears that there is an inappropriate transfer. Now we're at questions. And I have not been monitoring the chat.
So I will help. We have a couple, and we also have been trying to answer questions as people ask them.
Okay, great.
So the first one I wanted to mention, there was interest in what the Enriched Residential Care Program is, and Jean put in a link, and I mentioned that it's a program of the Los Angeles Department of Health Services for their clients. It's DHS is able to place clients that are associated with DHS into assisted living facility, and they call that enriched residential care. So you do, generally you have to be a client of the Department of Health Services medical system to get access to that program. The other one, though, I'm going to let you talk to a little bit, Molly, is that there was a question about whether enriched residential care or an RCFE will accept the client who only has Medicare or Medi-Cal. So I wondered.
So Medicare and Medi-Cal generally do not. Medicare does not pay for a residential care facility for the elderly or an adult residential care facility. Medicare will only pay for skilled nursing. and also only for a short period of time. So somebody who is on Medi-Cal, generally they often have SSI. And so you can find a facility that accepts the SSI rate and will, have that person stay, at that agreed upon rate. And then there are facilities that are part of the assisted living waiver program that will also augment. So they have special contracts with certain residential care facilities for the elderly, and Medi-Cal does pay for a portion of the care, not room and board. That's paid for by the individual through usually their SSI, but it will supplement payments and provide additional oversight and a social worker and a nurse and some additional support for folks. But the facility has to be part of one of the designated assisted living waiver programs, and there's only a certain number of slots. The client needs to have skilled nursing level needs that can be managed in this environment. So, and then the ERC program, they do accept individuals who are Medi-Cal, and they also augment the rate with certain facilities they contract with. And that's the program through DHS.
So Jean is mentioning that she has a list of RCFEs that take SSI eligible clients. So we'll get that out after the session. I also will provide a link to the assisted living waiver web page on the DHCS website. And then maybe it looked like Jean also provide a little more information on enriched residential care.
Oh, great.
So, so that is, those will be resources afterwards. And Jean's acknowledging that Molly gave her the list. So it's all very part of the family. So
yeah.
Good.
Yeah.
Okay.
Yeah. And you can always ask the ombudsman for the updated SSI list, because it's a really interesting thing that licensing doesn't keep a list of which facilities accept the SSI rates. There's really nowhere to get this list unless you get it from us, or you just haphazardly find facilities that will accept the rate. And you're like, oh yeah, I know that one will, I know that one will, but this one is city and county wide. So, and it's an ever shrinking list, unfortunately, but it is a list, and it does cover the city and the county.
Great. So I think we've covered all the questions in the chat, although it looks like some folks are still writing. And everyone's saying they'd love their list.
Yes.
And they're thanking you, Molly, for all the valuable information. I would, while we have up these phone numbers, I want to just offer the option if anyone would like to go on audio and ask you a question. We want to give everybody a minute on that. Not necessary, but an option.
I have a question and sort of like a case to share. It has to do with the SNF transfer, not to a shelter, but I had a client who the SNF, I guess they found that they couldn't manage his needs, not because they were too advanced, like you were saying, subacute. I think he was very overweight. And so it was a real strain on their staff. And so they transferred him to a boarding care, but he couldn't afford the boarding care. And so I don't know, is that part of like what they're supposed to do if they're going to plan a transfer? It should be to a place that he could afford, because then what ended up happening was the boarding care sent him to the hospital so that the hospital could arrange for him to discharge to another place that he could afford.
Okay. Yes. So at the moment, depending on how long it took for you to determine that, this client was transferred to the boarding care, because that's completely inappropriate. So,
yeah, we didn't know for quite a while.
Yes, that becomes the hard part. So I did have one case where I had a client who was transferred. I had a hospital call me and they were like, we just need some referrals. And it was a client who was a bariatric patient also, who and that there are certain groups of clients who are very hard to place. That's one group. Young people with multiple sclerosis is another group. So there's just different groups that take a greater degree of staffing time, and that equates to less money for the facility, right? So more work, less money, not the ideal person for them in their view. So I had a hospital call me and they said, I just need these referrals. And so we started and I said, well, where did the person live before this? A skilled nursing facility. But the client was at the hospital for a year.
I hear that sometimes happens, yeah.
And I said, well, that looks like an illegal discharge. Let us explore it. We were able to get that client back to that nursing home a year later. I'm not saying we're magicians. I'm not saying we can always make that happen. But once in a while, the discharge is so bad and so egregious that you can. So I would always advise, if you have those situations, to contact our office, and we can at least talk it out and figure out what the best course is. And we can always try. We can always try and do an appeal. And that's what we did in that case. Is we did an appeal through the Department of Healthcare Services. We went, because the facility wasn't going to let us negotiate them back in after a year, and we won. So I think, it's always good to kind of like, we always throw it to whatever agency we can and see what sticks, right? But yeah, definitely a skilled nursing facility saying that they can't care for that patient is inappropriate.
Thank you, Molly. Thanks
From what
so
you've
much.
described.
Yeah, thank you for sharing that case. That's a really great example, Kathleen. Okay, any other questions or situations that anyone would like to share on screen or audio? Okay, I think we've got all our questions answered in the chat. We've been saying this in the chat, but I just want everyone to know we will be sending out the recording, and we will be also being sure you have a PDF of this presentation, as well as any lists that we've mentioned. I think we've talked a little bit about what you were seeing through the case that Kathleen shared, but is there anything else that you'd like to share with Molly about any other experiences you've had, or anything else that you're seeing on the ground? She loves to hear the stories. Anything else?
Let me see, raise a hand.
I know Victoria is involved in a lot of cases, so.
Well, I'm not, I just provide resources for our care coordinators, but I was interested in what Molly said about cooperating with the Department of, Adult Protective Services.
Okay.
So maybe to give an example, I'm thinking particularly in relation to the CES system, which I'll be learning about later, but if you could give an example, maybe.
So an example of how we work with Adult Protective Services?
Yeah.
Yeah, so for example, we might have an abuse situation that was happening out in the community, like an abusive family member, and Adult Protective Services had been investigating that situation out in the community. The client gets placed in a skilled nursing facility. So APS might be investigating the abuse that happened out in the community, and then the abuse might start trailing into the facility, right? So we might have an abusive situation that's now happening in the facility. And so we're working on maintaining the safety of the person in the facility, while APS is looking at issues that happen in the community. And then if we're able to, if we have permission, because then we collaborate on, on what we're both hearing and seeing.
Thank you. Thank you.
Mm-hmm.
Great. Okay, anything else? Anything else that anyone would like to share?
It looks like Alana had a question about would a SNF discharge someone back to their home for a short-term stay, for example, within a home and community-based waiver or an MSSP waiver. Usually not for a short-term stay in the community, but that would be more of something that they would hope for, to have more of a long-term, have that be more of a long-term.
So I would like to suggest another waiver program, the Community Care Transition Waiver, that is also a Medi-Cal funded program that provides resources for individuals to go back into the community from a skilled nursing facility. I think it's normally been 90 days they have to be there, but I think now with COVID it's 60. And so it's a great support system to get folks placed back in the community. Mm-hmm. We can send that link out also.
Yeah.
Great. Okay, I think our last little thinking slide is there anything that from what you've learned today that you would do differently? Has it helped you be more confident in handling these situations? So if you want to go on audio, you can. If you prefer, you can just put your thoughts about this into the chat.
Or you can just think about it.
Yes, I think that's probably what we'll do is we want you to be thinking about what you've done today that actually will make an impact in how you operate. So we won't belabor that, but we do want to make sure that this becomes practical. So, okay. Okay, we will be sending out an evaluation. CSH always loves to get feedback, and we know that Molly does an outstanding job, so we want to be sure that you tell her that. We promise lots of resources, lots of information, but we also would like to hear from you on how we did today. So with that, I think we're done. I'm going to pull us back to the shared screen. We thank you so much for your participation. It means a lot to us. A lot of you come to many of the trainings that we offer, and we're always really glad to have you. So I think with that, unless there's anything else, we'll sign off a little bit early today and give you back a little bit of time.
Thank you.
Thank you, everybody.
Thank you.
Thank you.